Dr. Mohit, third year DNB nephrology resident from Asian Hospital, and today I'll be presenting my case. So, good evening to all the fellow residents as well. So, I'm presenting the case of Mr. ABC, who is a 35-year-old male and is a single person and a worker in a general store and resides in Faridabad. He presented with facial puffiness and swelling of bilateral lower limbs since 2 months and frothy urine for the past 15 days before admission. Coming to the history of presenting illness, 35-year-old male with no previous history of comorbidities presented with facial puffiness and swelling of bilateral limbs since last 2 months. He first noticed swelling around the periovital region bilaterally, and after a few days, he then noticed swelling around both the ankles, which later progressed towards the knee. It was insidious in onset, gradually progressive, and the swelling was splitting in nature. The swelling, as per the patient, was more pronounced during the morning hours, and it subsided towards the daytime. There was no history of any pain, redness, or any discharge from the swelling. He also mentioned that before coming to our hospital, around 15 days before that, he also noticed having froth in urine. Coming to the negative history, there was no associated urinary complaints like decrease in urine output or a cola-colored urine or hematuria or nocturia. There was no history of polyuria, polyphagia or polydipsia. There was no history of fever or sore throat or symptoms suggestive of upper respiratory tract infection or skin infection. There was no history of rash, photosensitivity, joint pain, oral ulcer or alopecia. There was no history of shortness of breath, orthopnea or paroxysmal nocturnal dyspnea, chest pain, palpitations, cough or hemoptysis. And there was no history of abdominal pain or any distension, jaundice or GI bleed. No history of altered bowel habit, decreased appetite, weight loss or generalized weakness or easy fatigability. And no history of bone pain, backache or any excessive sweating. There was no history of hearing loss or visual abnormality. No history of regular intake of over-the-counter drugs, indigenous or herbal medication or any drug abuse. No history of allergy or dust to pollen grains, and no history of recent immunization. As the following symptoms were there, he had consulted a physician near his home where he underwent some lab investigations and urine examination, and he was informed that though his physical and routine lab tests were normal, there was presence of leakage of urine in his leakage of protein in his urine, and thus he was advised to consult a nephrologist, and then he came to our hospital. History of past, shall I continue?
Yeah.
History of past illness. There is no history of diabetes or hypertension, no past history of tuberculosis or blood transfusions, no history of similar illness in the past, and no history of hospitalization for any medical or surgical illness. Family history. He is a single child born out of a non-consanguineous marriage, lives with his parents, and his parents, as informed by the patient, are also having normal health. No history of hypertension, diabetes or TB in the family, no history of any known kidney diseases, and no history of any similar symptoms or illness in the family members. Personal history. He is a non-smoker, non-alcoholic, takes mixed diet. As mentioned by the patient, his sleep pattern was normal, appetite was normal, bowel habit was normal as well. Shall I summarize now?
Yes.
So, 35-year-old male without any comorbidity presented with gradual onset of lower limb edema and facial puffiness with frothy urine for the last 2 months without oliguria, hematuria, abdominal distension, dyspnea, orthopnea, without any history suggestive of autoimmune illness. So, my provisional syndromic diagnosis is nephrotic syndrome, and etiological diagnosis. I would like to keep membranous nephropathy as my first differential diagnosis and focal segmental glomerulosclerosis as my second differential diagnosis.
Any other syndromic diagnosis? No.
Ma'am, I would like to keep nephrotic syndrome.
I think it's quite straightforward. There's not much thought in it.
Yes, ma'am.
Right? Any alternate diagnosis besides nephrotic syndrome? Congestive heart failure?
Ma'am, yeah, so if we assess for any other systemic...
Liver disease?
Yes, ma'am.
So anybody who presents with edema, there are 3 things you need to think
Yes, ma'am.
about.
Yes.
Liver, kidney, heart.
Yes, ma'am.
So any thoughts on congestive heart failure or chronic liver disease? I think that's where you would
So
say
as
something.
for a similar complaints, we have to rule out other systemic issues as well. So if we consider any cardiac issue, so as I had asked in the history, patient mentioned that he did not have any history that was suggestive of orthopnea or a paroxysmal nocturnal dyspnea. Moreover, there was no history of any cardiac event or any issue related to the heart mentioned by the patient previous to this admission. So it's
So
yes, ma'am.
basically there's no dyspnea at all.
No dyspnea.
Forget paroxysmal, forget nocturnal,
Yes,
but there is no breathlessness at all.
yes,
Which would more or less rule out a congestive heart failure.
yes.
Right?
And coming to the liver disease, so ma'am, as mentioned by the patient, there was no history of jaundice or abdominal distension or any viral illness as such mentioned or he was diagnosed with in the past. So again, any history suggestive of a liver disease was not there as provided by him. So again, that looks to be a little less likely differential diagnosis.
Okay, so I mean, if I were you, I would say no disproportionate abdominal swelling
Okay.
and presence of proteinuria, which he has been told.
Informed.
So those two would go against liver disease, and you can then more or less isolate kidney disease here.
Ma'am, again, the pattern of onset of the swelling, as mentioned by the patient, that first he mentioned it was a periorbital puffiness, which later on, as progressed, involved the ankles as well. So that again slightly points more towards a kidney origin of the disease process, or
No, I kind of agree. It's quite straightforward. This is a nephrotic syndrome, and that is what it is. Okay, so how will you examination?
okay.
Anything else, Anna? Anything strike you? It's so straightforward. I don't have much to ask. So examination.
Ma'am, examination. Should I give it full detail? Actually, there was no any acid positive finds, but I'll just go through the slide. Okay, ma'am. So he was conscious, alert.
Do you have a biopsy and all to go forward in this
Ma'am,
case?
actually, biopsy was done 2 days back, so I don't
Okay,
have
so
the
you
report.
don't have the results.
Yeah, the report is not there.
Sure. Okay.
So, patient is conscious, alert, oriented to time, place, and person, and he was maintaining a decubitus of his choice. His build was average, nutrition was good, height was 5 feet 11 inch, weight was 73 kgs, BMI calculation of 22.5. Blood pressure was 130 by 70 mmHg, measured in both arm in supine position. There was no postural hypertension. Supine blood pressure was 130/86, and standing the blood pressure was 126 by 80. Pulse was 84 per minute, regular, normal in volume and character, without any radial or radiofemoral delay, and all the peripheral pulses were palpable equally. The respiratory rate was 16 per minute. It was regular, thoraco-abdominal in character. Temperature is 98 degree Fahrenheit, and room air oxygen saturation was also normal, that is 98%. Pallor, icterus, jaundice, cyanosis, clubbing were absent. The JVP was not raised, lymph node was not palpable. Edema was present bilaterally involving the ankles, and it was progressing towards the knees. Condition of skin and hair was again also within normal limit. Abdominal examination, there was no positive finding, there was no distension, and no feature suggestive of an ascites.
You have
Cardiovascular.
actually done a genital exam?
Yes, ma'am.
So, yeah.
Yes, ma'am. Yes, ma'am. Yeah.
You have actually done it?
Yeah,
No
yeah.
scrotal edema?
Ma'am, scrotal edema was not there. I did not do the per rectal, ma'am, but I did do
No,
the
I'm not asking. I wasn't even asking for genital edema.
scrotal edema was not there.
Was not there.
Was not.
Okay. Surprising.
Cardiovascular examination, ma'am, S1 S2 were normal to be heard, and the apex beat was present 2.5 centimeter medial to the mid-clavicular line. And respiratory system also, ma'am, the breathing movements were equal bilaterally. There was no added sound. Normal residual breath sounds were heard bilaterally. CNS examination as well, ma'am. The findings were within normal limit. So after the examination, my syndromic diagnosis and summary, ma'am. So he's a 35-year-old male without any comorbidity, presenting with gradual onset of idiomatous illness for the last 2 months, probably due to nephrotic syndrome. And etiological would be, ma'am, again I would like to continue with the two, that is membranous nephropathy and FSCS, focal segmental hematosclerosis.
Okay, so that's a very straightforward presentation. I wanted to ask you, why are you looking for radiofemoral delay in this patient?
Okay, sir. Sir,
What is the bearing of radiofemoral delay in your patient?
Sir, I did it as a part of a routine examination also, and coming to our
So
case.
if you have radiofemoral delay along with this presentation, what do you think of?
Sir, I need to rule out if there is any issue pertaining to, first of all, the vasculature. Like we know that radiofemoral delay could be involving the aorta, that there could be an coarctation of aorta or a Takayasu arteritis. So I just wanted to be sure that whether is there any autoimmune or vasculitis etiology that might be somehow contributing to this disease. Or
So do you think any autoimmune kind of a disease can give rise to this kind of a presentation?
so autoimmune
Vasculitis or something? Can it
would be less likely, sir. It would
Yeah.
be less likely.
Less
sir.
likely means it could be possible that
no,
you
no.
can have?
No, not possible. I mean to say the symptoms would have been a little different. The presentation would have been a little different. So yes, sir. So,
So it's very important when you're doing a general examination or a physical examination. So stick with what you're looking for in the patient. The examiner doesn't want you to go through the entire list of examination.
okay, sir.
Okay, because it has absolutely no implication or no bearing to this case. Secondly is whenever you examine for edema, how do you examine for edema?
So first of all, like in case of this patient when he was having swelling in the bilateral ankle area, so I did it in standing position, and I first I removed the clothing from that area, and then I did a general inspection to visualize how exactly the region looked. After that, sir, I proceeded to the palpation, where I palpated first of all just above the medial malleolar and with the thumb, and I kept it for about 30 seconds. So after that, I removed my finger. That was to assess for any pitting nature if present.
So you have to mention in your examination whether it's pitting or non-pitting.
I mentioned that, sir.
No.
It's
not pitting, it's just edema.
Okay, sir. I have
It's just edema.
Okay.
Yes, right. There's
Sorry.
no pitting there. So,
Okay, sir.
what is the implication of a pitting and a non-pitting edema?
So whether the edema is pitting or non-pitting, so it again takes us towards the possibility of some differential diagnosis. In case of pitting, the common etiologies include, like in this case, a kidney disorder or a cardiac issue or a liver issue. Non-pitting usually could be due to a thyroid issue or even a long-standing pitting edema when pertaining for a long time, that in later stages could get converted into a non-pitting edema.
That means endocrinological causes will give rise to
Yes, sir.
non-pitting.
A non-pitting edema. Yes.
This will give rise to pitting edema.
Yes.
And why do you have to make a patient stand when you check for edema?
I was surprised. Why did you make him stand?
Ma'am, it's not necessary. I mean, that is how I did. Actually, I did in both supine as well as in standing
No,
posture.
one second. So the problem is, if you do this unnecessary stuff, you put yourself in trouble in the exam.
Okay.
I see no indication where you would make somebody stand or lie down, or even mention the position while examining it. जहाँ वो बैठा है वहीं देख सकते हैं, जहाँ वो खड़ा है वहीं देख सकते हैं. आप खड़े को कौन examine कर रहा है आपको? So you normally, the patient is lying down or at least sitting in bed, and you do it. The moment you say you did it in standing, lying down, you're putting yourself in trouble. It's not JVP. It's just plain simple edema. So if you do unnecessary stuff, you are again putting yourself in trouble. So larger distinction of pitting, non-pitting is pitting usually implies fluid retention. Non-pitting would be, as Dr. Bhargav said, either endocrine causes or lymphedema. That's the other, and chronically very tight edema. That also, if you pit for long enough, you will probably find it pitting. Okay, so that would be a very short answer. And whenever you get into trouble like radiofemoral delay, I think you should have confined yourself to it's part of routine physical examination. You would have been safer. To fit this presentation into a radiofemoral delay, it's very difficult. Because the guy is not even hypertensive. He's without medication, he's not even hypertensive. What do you make of all the vascular disease? Then nothing. So I think more pertinent in this history would be to exclude, let's say, secondary causes of nephrotic syndrome in a systematic manner. So the common systemic diseases, which very often will lead to edema or secondary nephrotic state at 35 years of age, you have to think what are those reasons in your head, 1, 2, 3, and exclude them in an organized manner. So in order of frequency, I would say that's diabetes. 2 would be maybe SLE. 3 would be some multiple myeloma, paraproteinemia. Anything else that strikes you people? Anybody is free to answer. So these systemic causes would be, and such gross edema. Yeah, मुझे खाने को कुछ नहीं चाहिए. You want something? No. मुझे लगता है खाते ही नहीं ऐसे. नहीं चाहिए. I certainly. So that makes more sense. So, and if you put them in some organized method, it's always better so that the examiner gets a sense what are you trying to exclude. So, if I were you, I would say in one breath, photosensitivity, rash, joint pains, everyone thinks now it's SLE excluded, no history of diabetes, not a known diabetic is simple enough, that way. Paraproteinemia, you could have included bone pains somewhere. You mentioned that. So, because it went so many of these negative histories. So in negative history, according to me, there has to be a system, not a rattling of various symptoms. But either it goes, as the Americans say, review of systems, chest, abdomen, heart, whatever. Or you think about diseases in your head and exclude them one by one. So those are the 3 which come to me as a secondary cause of nephrotic syndrome at this point, and you could exclude these 3 in a systematic manner. So there should be some organization put in this negative history. That's my thought. Right?
So there's this thing about the fact that you said that this patient had periorbital edema, and then you noticed that he had swelling in the lower limbs. And then when you do the systemic examination, you say that there is no scrotal edema. So what does that tell you about the glomerular disease or the proteinuria disorder that he has? That he has periorbital edema, he has pitting pedal edema, but he has no scrotal edema and no ascites as per the examination.
So it could be slowly progressing glomerular disease. I would think of that.
So would you think of something which is an exorbitant proteinuria here, or something which is a non-exorbitant proteinuria?
So it would be towards a non-exorbitant proteinuria.
Would also you think of the disease onset as being very long or very short?
So short.
So anything which is short, lesser proteinuria will have this kind of a presentation if the presentation is correct. Now, if I was to ask you that, why did you put membranous glomerulonephritis as the first and FSGS as the second from your history? And why did you put minimal change and IgA?
Okay, sir. Sir, from history, first of all, the age of the patient, that is 35 years old. So, sir, as per the epidemiology of these diseases, usually at this age, membranous is seen in about 40% of cases of nephrotic syndrome. FSGS is slightly lesser, about 35%. And minimal change disease usually more common in cases of children. In adult, it is usually less than 10 to 15% of nephrotic syndrome cases. So first of all, as per the age, I felt that membranous nephropathy seems to be the first differential diagnosis. Moreover, sir, the fact that he did not have hypertension, the fact that there was no history of any redness, discoloration, the fact that there was no cola-colored urine or any specific history of an acute febrile illness nearing or a little far from these events. So I thought that IgA nephropathy or a proliferative glomerular nephropathy would be a little less likely option. And pertaining to minimal change, sir, again the fact that it's usually at a lesser, more common in children. So that's why I felt that membranous should be the first differential diagnosis among all these causes, sir.
Well, I would argue and say that this is probably IgA nephropathy, because this is a young male who's presenting from the Asian region, and the recent epidemiological study says that IgA nephropathy from our subcontinent presents as nephrotic syndrome more commonly as compared to any other subcontinent.
Why is that? Why does it present as nephrotic syndrome in our country? Anyone else wants to answer that? You guys contribute here. Anyone else wants to? Yeah, come on.
Because our country is a developing.
Yeah, Jones. So whoever can come forward, please come.
And likely it's a developing country, more source of infection. That can be the reason behind that.
Disease is a disease. whatever the source may be. IgA is not related to infection, isn't it? It's a kind of an abnormal response from our body in a way. So it's because we detect them late. We seek medical attention late. So if we were to do, let's say, epidemiological studies where we studied all children with urine examination, there's nothing else. Plain simple urine protein examination, we would pick up a lot of microscopic hematuриas and then biopsy them, and some of them would be IgA nephropathy. But there are no health checkups. Okay, so that we detect them late, they present late because the early disease is asymptomatic, right? So what would be the early signs and symptoms of IgA nephropathy? So I'm including signs and symptoms both. It would be, I mentioned one already, microscopic hematuria and hypertension. Nobody gets any of these two checked, right? So that's why early detection goes missing and we detect them late as nephrotic. But most of them would be hypertensive. That could have been your argument here. Absence of hypertension. It could have been your argument against his proposal. The guy is not even hypertensive. Right? And again, your second answer on minimal change. So when you are presenting an adult nephrotic state, you don't have to say minimal change is more common in children. Your job is not to compare it with the frequency in children versus in adults. Your job is what you said epidemiologically, if we look at data. So between these two and the third one, which is minimal change. So between these three diseases, clinically there are hardly any things which will take you this way or that way. Hypertension would go against minimal change a little, but besides that, you don't have much to say one or the other except the frequency of that disorder. Do you think now the frequency has changed over the last, let's say, 30 years? Is the data different, what it was 30 years ago and what it is now? I may be wrong on 30 years, but somewhere, let's say, a little remote past at least for you.
The incidence of FSGS has increased over, like, if you compare to the data 30 years back and now.
Right.
So now the most common cause is progressing towards FSGS in adults.
Correct. So if you see most data, membranous used to be very common. So that may be related to what he said, infections. Earlier, infections were more common. So somewhere, but now we know membranous has nothing to do with infection. Again, so most of this membranous is primary or secondary?
Primary.
Primary. So because again, secondary was associated with Hep B. That's vanishing from the scene. So you don't see secondary, and primary is also coming as if you compare the two. So some of the previous commonality of membranous may have been infection related, and some of them may have been secondary, possibly. Okay, so how will you proceed further in this?
Can I show my investigation question? What I have done?
Yeah, investigations, come to investigations. Anything else anybody wants to know in history? Any of the students, any clarifications? Because this is so simple and there's not much to talk here in this patient. Just one symptom, one sign, and that's it. Okay, investigations.
So, ma'am, I'll proceed with the investigation. So, what we need to do is we need to assess that, first of all, the DDs that we were thinking, we have to proceed towards whether it is actually that or not. Secondly, if it's a membranous or if it's any other disease, we need to know whether it's a primary or a secondary cause which is causing this etiology. So, starting with investigations, first of all, routine blood investigations, which included a kidney function test. So, our patient had a normal kidney function with a creatinine of 0.8, the GFR was 116 at this value. In the liver function test, I wanted to assess for the total protein as well as the albumin levels. So, the total protein was 3.3, which was decreased. Albumin was 1.7, which was again lower. And in the complete blood count, I wanted to look for possibility of any presence of any anemia. In his case, the hemoglobin was 14.9, and TLC count just to assess whether if there is any infection. The thyroid profile, the TSH value was 3.7, which again was in normal range. The lipid profile showed derangement whereby the triglyceride level was 359. The total cholesterol level was 359. Triglyceride was 202, LDL was 346, VLDL 67, HDL 42. So it was a deranged lipid profile picture. PTINR and APTT were within normal range.
So what apart from the TLC you want to look at the CBC when you're looking at this kind of a patient?
So first of all, one is anemia, where I want to know that some secondary causes like
So if you have anemia and you have this kind of a presentation, what are the differentials?
Sir, one is the possibility of a multiple myeloma. Second, I would like to know that whether the patient at this stage itself is a chronic kidney disease patient, because maybe like in case of an IgA nephropathy, as we know that the detection sometimes is late, so a patient might first time present with this set of symptoms, and the fact that he is anemic and
So will you think of multiple myeloma in this patient?
no sir. Again the
So,
age is
Again, I'm
slightly
asking from the perspective of this patient, that if this patient had low hemoglobin and he has this proteinuria disorder, what are the differentials in your mind?
So one would be a lupus nephritis.
You think this patient would be
Again,
lupus?
you know, sir, less
Ruled
likely.
out
Sorry, sir.
everything.
Yes, sir. In this patient, no, sir.
Which is the glomerular disease pattern which is associated with anemia, with proteinuria?
He has something in mind from your differential diagnosis, the two differential diagnoses.
So
Am I
FSGS can happen.
FSGS. So how many FSGS till now you have seen who've got anemia?
So one of the etiology for secondary FSGS, that would be a sickle cell anemia. So that okay. Sorry, sir. Not good.
So MPGM pattern is the only pattern because that's a secondary disease to some other illness that is generally associated with some autoimmune disorders, and so you can have anemia in these patients. So if you have an MPGM, a primary MPGM, they will present with anemia and nephrotic. What else will you like to see in CTC apart from anemia and TLC?
Yes. So one is
Because in this patient, I'm not interested in anemia. I'm interested in a lot of other things. Because here I can see the albumin is 1.7 and you're saying those totally do not. So I'm still thinking what it was. Are you looking more at hemo concentration or are you looking more at anemia?
could be hemoconcentration due to intravascular hypovolemia, which can be there due to
So,
lower protein levels.
When you're looking there, I think it's more important for you. Why do you think you want to look at hemo concentrations? Why?
So because considering the fact that in the nephrotic syndrome there is loss of albumin, there is decrease due to the Starling forces, the blood plasma osmotic pressure is less, so that leads to the pushing out of fluid from the intravascular compartment into the extracellular space, which is also part of the underfill theory for nephrotic syndrome. So again, that could lead to intravascular hypovolemia, which can lead to this hemoconcentration and present such a picture.
Yes. So how will it help? How will it help you in managing this patient?
So that would be in such a way that so it could be pointing to the fact that the patient, not in this case, but he might have an acute kidney injury because this intravascular hypovolemia can lead to precipitation of an acute kidney injury on top of a nephrotic syndrome. Secondly, the intravascular compartment, again, sir, one of the main treatment modalities is giving a diuretic. So diuretic in its way, that the fact that it can further precipitate an acute kidney injury in the presence of intravascular hypovolemia.
So what are the causes of acute kidney injury in patient with nephrotic syndrome?
Okay, sir. So one is this cause that it could due to the fact that there is decreased blood plasma osmotic pressure. So that's
So
why.
I'd like to put it like pre-renal, renal.
Okay, sir. Yeah. So this would be a pre-renal cause. Sir, intensive renal could be due to infections. As in nephrotic syndrome, there is increased chances of infections like like a cellulitis or a peritonitis.
So what does infection cause? Infection in the kidney or infection elsewhere? What does it cause? So you're talking about kidney here, not about outside.
That would be.
Yeah. So what are the renal causes?
Renal causes. Okay, sir. So one is this, and
So can anybody answer that? Why are you looking at hemo concentration in this patient?
So because albumin levels are on the lower side, and as discussed, that primary cause is membranous, which is most associated with thromboembolic disorders.
Yeah. So you're looking at a hypercoagulable state here.
ऐसा नहीं thrombotic state है,
Thrombotic.
thromboembolic नहीं है. And you know, a lot of people use them interchangeably, and I have a little objection to it. There is no embolus anywhere. It's just thrombotic. Okay? So don't use them interchangeably in general.
Renal vein thrombosis, which is again a
Renal vein
complication.
thrombosis or thrombosis anywhere
Yes, ma'am.
because of the nephrotic state.
Seen in
Chalo,
about
आगे
8%
चलते हैं.
population.
Let's go forward.
Coming to the urine routine examination, so this was one of the report. Actually, sorry, sir, this date I have written. No, sorry.
कोई बात नहीं, date को छोड़ दो. We haven't looked at it.
Okay, sir.
Doesn't
So
matter.
yeah, so the glucose level was nil, protein was 4 plus, pus cells were occasional, RBC was 3 to 4 per high power field. There was no cast that was visualized in the microscopic examination, and no crystals were there. The spot urine protein creatinine ratio was 8.43, and the 24-hour urine protein was 9.26 grams.
Okay, so one, did you do this urine yourself?
Yes, ma'am, I have.
You did.
I mean, I not independently, but I was with the microbiologist because I wanted to see how it was done.
Okay. So you should know how to examine a urine. So
So
did you
why
centrifuge it
chemistry?
yourself?
Yes, ma'am. So I what I did was that I took
Because
like-
there's nothing else in your patient, so I have to come down to these basic stuff.
So ma'am,
So did you
basically,
centrifuge it yourself?
yes, ma'am. I along with the microbiologist with
Microbiologist को centrifuge करने की क्या जरूरत?
I mean, ma'am, the technique.
Why do you need that person?
Okay, ma'am. So I did collect in the test tube, and then there's a centrifugation machine where
Okay.
he takes the test tube, and I ran it for 8 minutes at 3000 RPM. After that, we took out the test tube.
So you just put one test tube in the centrifuge.
I was going to concern.
No, no. I mean, there were other patient samples as well. There were about 12 slots.
So
in the
let's
machine.
say there was no one else in the hospital that
Yes, ma'am.
you just had this patient and only one urine examination to do.
Okay, ma'am.
Then what would you do? Left to yourself.
Okay.
You will put one tube and run it.
No, I mean, we can't. I mean, we should take it like.
Look, he and I probably have done some urine examinations in our life.
Okay, ma'am.
मेरी fellowship में तो routine में करना पड़ता था.
जी.
So ठीक है. So let's say there was no other urine sample. What would you do? You had one tube now.
Okay. So, ma'am, as in routine, urine routine.
ये centrifuge की बात हो रही है.
Yeah. So, ma'am, हाँ, मतलब उसमें we put the test tube. I ran it for. We did the centrifugation.
He asked just one tube.
Okay.
Then the other tubes are not there. Then what would you do?
Ma'am, then probably we can visualize is that uncentrifugated sample as well, probably like that. Okay, ma'am.
You have to balance a second.
Achha, that way, that way. Okay.
You have to put a tube opposite.
Empty tube, which
Not
was there,
empty,
filled
with a
with
similar
fluid.
amount of water.
Similar amount of fluid, ma'am. Water. Yes. ma'am.
Similar amount
Yeah.
of water. Fluid तो और क्या होगा?
हाँ,
Water.
जी ma'am.
So if you have done it, then you know it. If you haven't done it, you don't.
Ma'am,
It's
there
as
were
simple
odd
as-
samples भी थे, मैं तो बस इनका एक
नहीं, so basic फंडा नहीं पता ना अब
Yeah,
आपको कि
yes.
एक काउंटर बैलेंस करने को सेंट्रीफ्यूज में डालनी होती है.
जी.
नहीं तो वो वॉशिंग मशीन की तरह एरर दिखा देगा. ठीक है? So that's the beauty of doing something on the ground.
Yes, ma'am.
Okay. Then what do? You have done. You have centrifuged it. This time, always go and do one sample yourself. Forget the microbiologist. You don't need a microbiologist for this.
Yes.
Okay. And you always put a counterbalance tube with the same amount of water.
Water.
Right? Otherwise, the machine goes into imbalance. I never remember the RPMs. Somebody can tell me from here. That's 3,000 only. 3,000, 5,000, something like that in 2-3 minutes. 8 minutes.
Patients submit
Fine.
5 minutes, I think.
So, ma'am, digitally we could enter the data, so we entered 3,000
So,
and then
I can never remember that, but I don't have to appear in an exam. You guys have to. So you.
Generally, over 5
remember
minutes,
it.
you will end up destroying the urine sample actually.
मेरे हिसाब से कम होता है. 8
2
minutes is
minutes,
too long.
maximum 3 minutes.
Okay, ma'am. Okay.
Eight minutes is too long.
3,000 to 5,000 RPMs.
So then once it was done, I took out the test tube and then we decanted it. And there was a small residue that was left behind. Then there was another machine where it sort of gives some vibration, slight vibration, but which helps in mixing of that. That is what, or yeah, you could relate that. Yes, ma'am. So,
In my time, one took a pipette and just brought it up in that pipette.
yes, ma'am. So once that was done, then a drop of that was put on the test tube, and
On the
then we-
slide.
Then, yeah, on the slide, and then we put a cover slip, and then we visualize in the microscope. Under the 10x, ma'am, the differentiation was not possible. So then I looked under 40x. So there, I mean,
Differentiation between what?
I mean, on the structure, as in the epithelial cell or an RBC or a WBC. So that was visualized under 40x, and yeah, that is what I had done at that time.
Anyway, okay, let's go to this ratio. Why did you do both? 24 hours urine protein and a protein creatinine ratio?
Yes, ma'am. So, ma'am, as if the gold standard is a 24-hour urine protein, but you know, sometimes it can happen that due to not proper collection or due to some issue with the compliance of the patient, the value might not be the actual value. So, in order to be safe, we did the urine protein creatinine ratio also, which
One
is
second now. So let's say on a 24-hour urine protein, when you do, what do you do to ensure that this collection is reasonably good?
okay, ma'am. So, ma'am, two things. One is correct counseling of the patient so that he knows exactly how to do it.
Counseling करके समझा दिया.
जी. Secondly is, ma'am, looking at how much amount of urine the patient has passed. Sometimes the urine can be
I
less.
may pass 500 in
Yes,
a
ma'am.
day.
Yes, ma'am.
I may pass 3.5 liters in a day.
Yes, ma'am.
How does the amount matter?
Okay, so ma'am, in that case, we'll go with the 24-hour urinary creatinine value that
That's
is
what I wanted. So you must do the creatinine on the same sample,
sample.
on that the sample that you are doing
Yes.
protein.
Yes, ma'am.
That's missing here.
Okay,
So instead of doing a protein creatinine ratio to say if the two coincide, you should do a creatinine on the same sample. Do the right thing. So how much creatinine would be normal?
ma'am, in case of males, it is 15 to 18 milligram per kg in 24 hours.
Okay.
In case of women, it's slightly lesser. It's about 13 to 15 milligram per kg per 24 hours.
Anyone else? ये कौन सी किताब में लिखा?
Non-specific reference.
छोड़ो specific. Anyone from the back here?
20 to 25 for males and 15 to 20 for females.
This has been the figure for donkey years since I did a fellowship.
Sir.
15 to 20 for women, 20 to 25 for men. We are just imagining the two coincide. Have you ever read a study? Have you ever seen a graph that the two are related? Anyone else? सुनील तुम्हें तो पढ़ाया था 2-4 दिन पहले. हाँ, तुम्हें ग्राफ भी दिखाया था. चलो आओ उठो खड़े हो. तुम्हें तो पढ़ाया था मैंने, so you can't tell me कि नहीं पता. अरे 2 days, 3 days. Anyone has seen this relationship? Okay, the two have a good correlation. There's a very old kind of graphs published many years ago, but it's fundamental. Look, you can't just assume the two are related, right? Why are we assuming? So there have been studies where people did 24 hours urine collection, measured the protein in that, and did a spot protein creatinine ratio, and there is a reasonable linear relationship between the two. Okay, there has been a study like that, and I'm sure there are many more establishing a relationship. This was done many years ago, but that's a graph we all kind of use for teaching purpose. Okay, to say the two are related to, they are correlated in a way. Okay, so which is better, doing protein or albumin?
Ma'am,
You're stuck with fundals now today.
Ma'am, protein would be better because ma'am, albumin would be, say, in case of minimal chain disease, it is known to be selective for albuminuria. In conditions like, say, FSGS, it is known that it is not selective for albuminuria. So besides albuminuria, other types of proteins might be, like in case of a multiple myeloma also, we'll do urine albumin that may come out to be normal. But because that will not detect the light chains that are being the overflow proteinuria that we are having, that will not be picked up. So it's better to go with the protein because that will at least give us that, I mean, something besides albumin. If it's there, then it will be picked up by the protein.
What's your purpose of doing this at this point? Why are you measuring protein in urine? What are you trying to assess?
Ma'am, again, the range of proteinuria will.
You are trying to assess glomerular disease, tubular disease,
Yes.
vascular disease.
Yes.
Tell me one.
Glomerular disease.
Glomerular disease. So when you are trying to assess glomerular disease, albuminuria is more important. Alright. So ideally you should do albuminuria. protein creatinine ratios or protein estimation is cheaper than albumin, but albumin is specific to glomerular disease. Alright, so if I was looking at it, I would actually try to do albumin creatinine ratio. Protein is kind of a default because we've been doing it for years. We do. We just write protein creatinine ratio. So your logic is the other way around. So the logic you were trying to give us is the other way around. Alright. So overflow proteinuria is probably the only disorder or a major tubular disorder where you can find a huge proteinuria and a very little albuminuria. Right? That's what you call as overflow proteinuria. I hope everyone knows what is overflow proteinuria, what is filtered protein, glomerular proteinuria, and what's the third? Tubular proteinuria. Right? Okay. Because it's overflow, because the chains are being filtered, cannot be reabsorbed completely. So it becomes overflow. Right? So when you are looking at this, so multiple myeloma is not a glomerular disorder. If you find major albuminuria in a patient of multiple myeloma, what does it indicate? Give me a better answer. I mean, I'm not denying your answer, but give me.
No, renal amyloidosis could be.
Yeah, so that usually includes a disorder like MITD. Alright. So if there is significant albuminuria, a patient of multiple myeloma, that is what it indicates. Some kind of deposit disease in the glomerulus. So these little things can give you lots of clues to disease, provided you have background knowledge. What does 4 plus mean?
4 plus would mean that it is more than 1000 milligram per day.
Let's say you do another urine routine on this person. This was done on some day, and you do another, and that's 1 plus. Then, do you think he has reduced himself from 1000 milligram to 100? What could be the difference? And that data is missing from your report.
I did this.
Okay. This must have happened. Many times it comes as 1 plus, many times it comes as 4 plus. So, nephrologist's mind, Sherlock Holmes working. So,
I mean, it could be the amount of urine, or it could be that it's a concentrated sample and the specific gravity.
So that is why you should have specific gravity up here, right? So if this is on a dilute urine, it becomes very significant. If it's on a very concentrated urine, it's not so significant. 4 plus will always be significant, but you must understand in your head that specific gravity should accompany this report. Okay, what does it detect? It says protein, glucose protein. अभी हमने नीचे वाली बात करी protein. So what protein is this? 4 plus. Albumin, globulin, chain, light chain, heavy chain, kappa chain, lambda chain.
In this case, it could be albumin.
Could be.
I mean,
What is
albumin.
could be?
I mean, it is albumin. Yeah.
Dipstick detects only albumin.
Yes,
So that should also be very clear in your head. Dipstick detects.
only albumin.
These are actually, you should write instead of protein,
Albumin.
albumin. I don't know what does the stick say. But at least when you put data, call it albumin. Okay?
Right.
And you should know in your head that the dipstick detects albumin, this is all protein. Okay? Chalo, अब आगे चलते हैं.
The viral markers were negative, and for autoimmune profile, we did the ANA by IFA, which was negative. C3, C4 levels were within normal range. Anti-PLA2 receptor antibody we wanted to send, but the patient could not afford it, so he had refused for the same, so we could not send the investigation. We did the ultrasound, which showed normal sized kidneys, and it was a normal picture. So he underwent a renal biopsy day before yesterday, so I don't have the report with me right now. So this would be the presentation per se, and after these particular findings, my diagnosis would be a nephrotic syndrome, and I felt the first really should be a primary membranous nephropathy, the etiological cause for.
Has anything in the investigations taken you towards one or the other.
I mean, yeah, it is difficult to. Maybe I can again due to the age. I felt that.
हाँ age तो पहले भी पता थी.
जी, जी.
So nothing new has come up in the examination.
Examination.
Nothing new is not investigation. The labs.
Labs.
Anything in the labs
Only thing
which
it is
takes
suggesting
you
that
one way or the
no,
other.
no, just pointing that it is a nephrotic syndrome, but yeah, again,
It is just confirmed. What's the definition of nephrotic syndrome?
Nephrotic syndrome, it's basically characterized by parameters which include protein loss of more than 3.5 grams in 24 hours.
Another thing, why do you call it protein loss like a patient does?
Proteinuria of
Yeah, I mean,
जी मैम,
I keep telling these fellows, be clear in your head what you're talking about. Why do you don't become a patient here? They are the ones who says protein loss.
so proteinuria of more than 3.5 grams.
So if you were losing same amount of protein in any other manner, let's say I bleed, I do something else, will I develop nephrotic syndrome? No. So it's the loss you are not bothered. You're bothered in some way about
Urine.
it's in urine. You used this word somewhere, leaking. That's another word you should. मरीजों को क्या भाषा है? हमारी भाषा ऐसी नहीं होनी चाहिए.
Okay.
चलो, so call it proteinuria rather than loss.
Yes, okay. So proteinuria of more than 3.5 grams in 24 hours. Ma'am, serum albumin value of less than 3.5 milligram per deciliter. Ma'am, then lipid, yes ma'am, deranged lipid profile, where like deranged cholesterol levels, deranged LDL.
Three essential things in the definition.
Yes ma'am.
Is lipid profile
Edema,
essential?
ma'am, generalized edema.
Why forget edema?
Yes, generalized edema.
Okay.
Fourth is
So I would begin with edema.
okay.
Edema, proteinuria, hypoalbuminemia. Simple. Other add-on things.
Then hyperlipidemia and lipidemia. These are the two more
All
parameters.
right. Okay. और सवाल होगा इसका. So how do you? Let's assume his biopsy shows FSGS. Okay. Now, how would you distinguish whether it's primary FSGS or secondary FSGS?
So, ma'am, primary FSGS is usually first of all due to idiopathic causes and
Yeah, it's called primary now rather than idiopathic.
yes, ma'am. So one is that, ma'am, and then there's another set of genetic causes.
No, she's asking on biopsy.
अच्छा, on biopsy.
नहीं पुराने में भी चलेगा.
Okay.
Anyway, so तुम कहीं से भी शुरू हो सकते हो differences में. Primary and secondary. I say this is secondary. He says it's primary, and he's right. So even with the existing information, biopsy में तो सिर्फ FSGS हमें दिखाई दिया और कुछ नहीं दिखाई दिया.
Ma'am, history में actually कोई secondary cause नहीं है. There's no secondary causes which would be.
Anyone else wants to say something?
Primary FSGS would be abrupt onset of nephrotic syndrome, while secondary FSGS would be nephrotic range proteinuria, but frank nephrotic
It will
syndrome
not be
is
there.
Correct.
Yes.
So secondary nephrotic syndrome usually does not have edema.
Even the proteinuria is lesser. It's usually not in the nephrotic range.
Usually not in the nephrotic range, but maybe the proteinuria is in the nephrotic range or high grade, but usually not nephrotic clinical. That's why I began with nephrotic history. So this guy is clinically full-blown nephrotic. Even before you do a nephrotic range proteinuria, he is nephrotic. Right? So that is the first thing which is against secondary FSGS. Okay, now we can go on to other things. Biopsy में प्राइमरी और सेकेंडरी कैसे पता चलता है?
उससे पहले
हाँ, उससे पहले एक hypertension, right? And lastly, you said he has no reasons to have secondary FSGS.
I meant the any
So
illness.
how will you what will you have which can give rise to secondary FSGS, for example?
Ma'am, there could be any history of intake of medications or drugs like ma'am NSAID or lithium or ma'am.
Lithium causes FSGS.
Sorry, ma'am, heroin.
Hang on.
Ma'am, heroin or
Pamindronate होगा बताएगा नहीं.
you know NSAID, pamindronate, And heroin ma'am, one is that.
देखो, you're mixing up. Don't get nervous. This is like more for fun than real marpetai. This is, I think, we should make education fun. So don't get nervous. You're mixing up things now. I know you must have read, but you're mixing up things.
So ma'am, one is the intake of these medications, which include
So,
like
okay, is that called secondary FSGS?
okay ma'am. So in
I
that
don't
case,
think it's called secondary FSGS. Secondary FSGS
Maladoptic.
typically is
could be due to a
reduced nephron number leading to FSGS. And there can be various reasons for this reduced nephron number. It can vary from a single kidney to a reflux nephropathy to VOR,
basically
anything. Even a membranous can have secondary FSGS. Any kidney disease can have secondary FSGS. So that is what is secondary FSGS. Okay, so history mein aur kuch?
one is possibility of any infections like HIV or CMV or the viral infections. They are also can cause
So, okay. So और कैसे distinguish करते हैं? Now you have a biopsy. क्या? Edema की history हो गई, nephrotic state. दूसरा क्या? Hypertension. Most of these secondary FSGS would be hypertensive. तीसरा on biopsy अब आ जाते हैं, कैसे distinguish करोगे primary और secondary?
So now, like in case of primary, due to
देखो histopathologically focal और diffuse में मतलब पता है?
Yes.
Focal segmental.
focal is ma'am less than 50% involvement of glomerular and diffuse would be more than 50%.
Segmental.
Segmental would be the entire glomerular tuft is not involved. There is a portion of the less than 50%
Portion
of the glomerular tuft.
Portion of the glom. Okay.
Yes, ma'am.
So focals, FSGS, let's forget the focal. Pathologically looks the same in both.
Yes, ma'am.
The only thing is secondary FSGS may have some larger gloms. Glomerulomegaly is more common than that. And how can you distinguish between them? On EM. So what will be the difference on EM?
The effacement of food processes that is there.
So primary is diffuse.
There is effacement.
This other one is
Yes.
segmental again. It's patchy or
It's
segmental.
not
So
continuous.
that can distinguish, and then at times you look for reasons. Alright, scarred kidneys or something like that. So that's how. So pathologically, they both look the same.
Yes, ma'am.
You cannot distinguish between them. Well, जो आप सब जो बोल रहे थे HIV viruses, what do they cause? What kind of FSGS do these things cause?
Collapsing type of
Collapsing, and that's an entirely different
Different.
ballgame. Okay, that's an entirely different ballgame. So, what all can cause collapsing now? Let's hear that.
So one is the HIV related
HIV,
infections.
आजकल देखता है?
नहीं,
नहीं दिखता. HIV is gone. It's all treatable. So you don't see highway now any longer. It's more or less a historical disease like syphilis. Next, what do you see? What other viruses can you think of?
cytomegalovirus and Epstein-Barr virus.
Theoretically, yes.
Parvovirus, B19.
Parvovirus. So that's something when he was asking anemia and nephrotic state, I thought he was aiming at that. So parvovirus basically can produce anemia. What does it cause to the blood, the hematological system?
Basically, bone marrow suppression.
So it can cause aplastic,
Aplastic anemia.
right? So anemia and AKI and nephrotic state would be actually, even in a normal person, it could be parvovirus with a collapsing. What drugs cause collapsing variant of FSGS?
Famindronate and
Pemidronate is one prototype. Anything else?
interferons and
I think pemidronate large. That's the
that was the most common because
Yeah, that's the
Famindronate
most
was
common. Correct. Others, I think, rarely mentioned are cyclosporin and anything. So largely pemidronate. I can't think of any other drug. Okay. So those could be the differences. All right. Okay, let's dig out something else. When I'm your turn, you have to dig something.
So, what is functional proteinuria? Like you have tubular, glomerulus, or overflow. What is functional proteinuria?
So functional proteinuria is where it is secondary to some like a physical activity, like excessive exercise. Any acute event like a severe exercise can precipitate certain loss of protein, which is transient. And if we maybe repeat a sample, say after the next day when the patient has been in his normal homeostasis, that might be no. So it could be a temporary finding. That is a functional.
Is it a physiological thing or
Physiological.
It's a physiological.
It is physiological.
So why does it take place? Functional proteinuria.
Um, so due to the
Anybody? What's the reason for functional proteinuria?
One is that the left, due to exercise, there is increased flow. Left renal vein gets, it's like just a nutcracker. It gets compressed between the two, and there is renal congestion.
So the primary problem here is the renal congestion.
Could
be because of an increased physiological load, and that causes a transient proteinuria. So generally, how we give the diagnosis in exam would be to say this is nephrotic syndrome. Then you have to describe whether it's a proliferative glomerulonephritis or a non-proliferative glomerulonephritis. And then after that, you go on to the pathological diagnosis. So that's the way it should be. So nephrotic syndrome, non-proliferative glomerulonephritis. My first differential is either membranous. We are still not convinced with your other differentials like FSGS. We would still place minimal change nephrotic syndrome here because of the absence of hypertension, irrespective of what the biopsy tells us. But from the history, from the physical examination, it appears that you would put membranous, then you would put minimal change, and after that maybe FSGS or IC. Now suppose this patient has membranous glomerulonephritis, primary membranous glomerulonephritis. How will you manage this patient?
Sir, as per the critical recommendations, sir, we need to risk stratify the patient. So there are 4 categories which include a low risk, a moderate.
How are you going to manage this patient?
Okay, this patient. Sir, at this stage, I would start with the.
We all know the KD2 recommendations. How are you going to manage this patient?
So at this stage, I would like to start conservative measures initially, whereby since he's having a large amount of proteinuria, we need to provide measures which can help in reducing the overall edema and reducing the proteinuria. So I would like to start with diet modifications where we should advise him to decrease the salt intake, which should be less than 3 grams per day. And in simple terms, you can simply explain to the patient that whatever salt that is being used in the diet at home, just don't add extra to the food, and if possible, try to reduce the amount of salt that is added into the food. Besides that, sir,
So how much salt would you tell the patient to take?
sir, the specific quantity as such, sir, whatever they are taking normally, just a pinful of that. I mean, I don't know specific amount.
Is there a recommendation on how much salt has to
Edema. I would address edema with
I'll proceed now.
exactly. Make it short.
So one is that. So second, the issue
Salt
that we're
and
having
fluid
is
restriction.
edema. So I would like to start him on diuretics. So if the patient is on in OPD setting, then in his case, I would like to start an oral diuretic like torsemide. So diator, that is torsemide. So I would like to start on that. Besides that, anti-proteinuric measures in terms of maybe ACE inhibitor or ARBs can be started in his case, because they will help in decreasing proteinuria independently.
They can be or they should be.
They are known to cause.
They can be or they should be. Like this is your patient. We are asking you how you are going to manage this patient.
Sir, they should be started.
They should be started.
In this patient, yes, sir.
So now let's describe your patient. This is a patient who has 9.6 grams proteinuria.
Yes, sir.
Who has an very low albumin,
Yes, sir.
and he has generalized anasarca.
Yes, sir.
He has no hypertension. Okay, now start again. How will you manage this patient?
Okay, so sir, in symptomatic management, in terms of edema, I would like to start him on.
So you counsel the patient about salt, you counsel it about volume intake,
Yes, sir.
and now you are going to manage it. So tell us how you are going to manage it.
So I would like to start him on diuretics, sir. that would be oral diuretic in this case. After that, so I would like to add an ACE inhibitor or a angiotensin receptor blocker, and I would once we have started that, I would like to follow him up to assess for the change in creatinine values. So if
So this patient has a normal blood pressure,
yes sir.
and you're going to start him on ACE inhibitor, ARB along with the diuretic.
Sir, initially I would like to start just the diuretic, and in coming days I will, sir, because we, in order to, once the edema gets better, it resolves. So once the edema resolves and clinically the patient is better, after that I would like to start the ACE inhibitors. And once they are started, we need to be sure that we need to observe for the change in the baseline from the baseline creatinine. So as per the recommendations, if it is more than 30%, then we first need to decrease the dose. And
Before that, what dose will you start him on? Of which drug? Let's
Uh,
narrow it down. और more हटा
So we are
दो.
talking about disease specific management.
नहीं, एक पेशेंट की बात कर रहे हैं ना, उसको क्या दोगे? उसको ए और आर नहीं समझ आता है, एक दवाई का नाम और एक डोज का.
ठीक है मैम. Sir, ma'am, I would like to start with telmisartan at 40 milligram once a day initially, and then I would like to serially monitor the change in the creatinine level as well as
How
the
many
potassium.
hours, how many days after starting will you do a repeat creatinine? Serially कितना करते रहोगे?
Okay. So ma'am, initially I would like to repeat it after 5 days. And at that time I would like to see, because initially when the process starts, the drug starts, we need to be the maximum possibility of initially in a case of no separate AKI emit, that would be, I would like to assess in the first 5 days.
Okay, so let's say what's the probability that his creatinine would rise after your telmisartan 40? That you are so stressed about it, that it will increase.
Basically, what I'm trying to ask you is that suppose you take telmisartan 40.
Yeah, what's the
You're
probability?
normotensive, you're telmisartan 40. So what's going to happen to you? Because what's going to happen to you is going to happen to this patient also. Even worse, maybe.
So I would, more than AKI, I would be worried about something else, and that's what he's.
Hyperkalemia also, hyperkalemia and
देखो hyperkalemia क्यों होगा उसको एक telma-40 से?
anemia.
नहीं क्यों हो? He has normal kidney function. Why would he? So you should be bothered about hypotension more than AKI. In which patient would? This is a patient who's
Already-
actually no, he is nephrotic, all right. But I won't bother to serially keep monitoring his creatinine unless I was doing aggressive diuresis. I had put him on a Lasix infusion. In that case, I would like to see his urea creatinine and potassium. But on oral torsemide, telmisartan, I don't think he is a very low probability to develop AKI after telmisartan. If this man was a bad heart failure, I would think high probability. If this fellow was a chronic liver disease, I would think high probability. Or he was a renal artery stenosis, that too he had to have bilateral renal artery stenosis. Okay, barring these three conditions, I don't think the probability of AKI with telmisartan is so high. I would be more bothered about hypotension in a normotensive individual. So personally, what I would do is starting on a low dose, like 20 milligrams, that to give it at bedtime. That's what I do, frankly, in my practice. So that the chances he would develop hypotension is less. He'll take the tablet, go to sleep. And most of the diuretic effect is gone by then. So give a diuretic in the morning, give ARB in the evening. Practical management. He will keep peeing during the day, not pee at night, and have the antiproteinuric effect of ARB at night. This is not written in books. ऐसी चीजें किताब में नहीं मिलती हैं, ये तो practically कर आके you start doing it. I don't know what you do. That's what I do with these fellows. But he's a low risk AKI, according to him. Alright, he doesn't have those real prerenal things.
आगे क्या करोगे?
So sir, once we have done this, sir, next is sir, like we have done the biopsy, so we wait for the biopsy report. Once the biopsy report is out,
आपको बता दिया
Biopsy
कि
तो बता दिया ना,
आपको मैंने बता
membranous
दिया
है.
membranous।
ठीक है sir.
उसमें और कुछ पूछना चाहते हो पूछो उनसे. He's saying membranous. You are free to ask him further details on the biopsy.
So then, like the blood PLA2 level has not been done. So I would like to ask whether the PLA2 staining
It's positive.
Is positive. So ma'am, in that case, now for the conservative measures we have given, now I would like to assess whether there is requirement of immunosuppression for this patient. So now comes the step when we need to assess what is the risk category for this patient, and which is basically decided on the basis
So
of.
on what basis do you decide risk category?
Yes, ma'am. So ma'am, it includes the renal status, that is the GFR value. Second would be the.
Which you said is normal.
Yes, ma'am. So in this case it's less. Second would be the amount of proteinuria. So a low risk would be less than 3.5 grams. Moderate risk would be more than 4 grams, and high risk would be more than 8 grams. So in his case, it is more than 8.
और 4 to 8 का क्या होगा बीच में?
Now 4 to 8 is moderate.
Is moderate.
4 to 8 is moderate, and more than 8 is high risk, and the third thing besides this would be the.
तो आपको रिस्क तो पता चल गया है
High risk,
हाई रिस्क है
Yes,
हाई
sir.
रिस्क तो
Yes,
आप
sir.
बताओ आगे बताओ
Okay, so since it's high risk, sir, I would like to
see I tell you don't get it wrong but when you're on exam nobody is there to listen to your literature they're there to assess in practical that this patient is sitting right in front of you on the bedside you're going to be passing and becoming a consultant or a associate professor so you should be knowing how to solve this patient's problems literature everybody knows literature. So we are giving you everything again and again. This is, I told you that in a nutshell, this is the patient. Biopsy shows evidence. Now tell us how to manage.
So, sir,
So then you're first starting with salt, then you're starting with this, then you're starting with Telma, and then you're starting with. But what do you want to really do with this patient?
So immunosuppression we need to give. Sir.
Yeah, because this is a high risk
High risk.
patient. This is
Yes, sir.
9 grams proteinuria.
Yes, sir.
He has severe hypoalbuminemia.
Yes.
Okay, so now tell us what you want to
Okay.
do.
So, sir, one of the options available is I can start with rituximab, where I would like to dose it at 375 milligram per meter square, and so I would like to give once a week for the next 4 weeks, and after that, if we are assessing with rituximab, that would be the method, or we could give the modified Ponticelli regimen, that is a combination of cyclophosphamide as well as steroids. So wherein we'll start with like 1, 3, and 5 months. We'll give steroids for first 3 days. Methylprednisolone 1 gram daily, followed by 1 milligram per kg for the remaining 28 days. And then 2 for 6 months, I would like to give oral cyclophosphamide at 2.5 milligram per kg. The third option would be combination of rituximab and a CNN.
Suppose this was a 70-year-old male.
Yes, sir.
Whose memory is.
I would have gone with rituximab, sir.
So then, would you like to change the dose of cyclophosphamide?
Sir, we would like to decrease the dose of cyclophosphamide because again the risk of the side effects such as the granulocytopenia, the decrease, that would be higher in an old patient.
So how much should you keep the dose?
Sir, in that case, I would like to give 1.5 milligram per kg per day.
So 1.5 to 2.
1.5 to 2. Yes, sir. That would be the.
Okay, so now you've told us about modified Ponticelli. Now, in this patient, what do you want?
So in this patient, I would like to start him on rituximab. I would, at the dose I mentioned that I would like to give.
I noticed somewhere that you said he could not afford an anti-PLA2
Sorry, sir. Yeah.
and you want to give rituximab. So that's where you will get stuck in your exam. Okay. Now, tell me how will you treat this?
So now I would, yes, sir, since we have to be considerate of the financial aspects as well, so I would like to start with modified Ponticelli regimen because the medication cost as compared to rituximab is way lesser as compared to rituximab. So I would like to follow the modified Ponticelli regimen like I mentioned that first month, third month and fifth month would be steroids and the second, fourth and sixth month would be cyclophosphamide. And in his case, I would like to start with the routine dose of cyclophosphamide because that he's not that old, and so I would like to start with that. Once we have started,
So when you do the modified Ponticelli, do you want to also do something else with the patient? You want to counsel patient and you want to see something before you start cycles.
so one is the complete blood count. I would like to know what is the baseline TLC levels, hemoglobin levels, and the platelet levels because there would be bone marrow suppression, which is a common side effect. Besides that, like in his case, he's a young patient, so we need to counsel him about the possible
So
side effects.
what
like
dose
other
does
people.
bone marrow suppression take place? Is it common for bone marrow suppression?
So bone marrow suppression would be at so the specific dose.
Have you used cyclophosphamide?
Yes, sir. Yes, sir.
Have you seen patients with bone marrow suppression? In your
The ones which I saw, I did not. No, sir. It's not that common.
It's very uncommon.
Yes.
What other counseling does he need?
Okay. So one is
For cyclophosphamide.
Yeah, so besides other side effects like alopecia, we have to ensure in case if it's a young patient, like in his case, there is a risk of infertility at a cumulative dose of more than 8 grams. So in such a case, we can counsel him about probably if in his case like sperm storage could be done.
PLA2R तो करा नहीं रहा, sperm storage कराएगा.
हाँ, जी मैम.
Any storage is expensive.
Expensive.
Any storage is expensive. So this is what I wanted to say. So once you give him the options, I'm sure he will choose rituximab, and you can go back and convince him to get a serum PLA2R. That's not that expensive a test. उसने biopsy भी तो कराई है ना?
हाँ मैम, correct. जी.
Biopsy भी 40,000 से कम नहीं
वो
है.
ज़्यादा महंगा है मैम.
PLA2R is what, 3,000?
5,000 का है मैम.
5,000. So if I were you, I would go back and convince him to get a PLA2R and tell him this can give you better therapy and better monitoring. So let's say you have done a PLA2R also now. Okay, and you have given him rituximab. Now what do you expect?
So
आगे का course बताओ.
yes, ma'am. So once it has been given, so ma'am, you would like to reassess what is the change in the PLA2R value, which is usually done after 3 months or after 6 months. So if say after 6 months, there is
When do you expect response in what? ये बता दो हमें.
ma'am, as in individual drug wise,
No, rituximab की बात हो रही है.
so ma'am, it would be usually after like 1 month the cumulative effect will start, and that will like
Cumulative effect on what? What is cumulative?
ma'am, okay,
There is
sorry,
just rituximab, 2 doses or whatever.
ma'am, after 2 doses, 2 to 3 doses it will start.
चलो ठीक है.
Yes, ma'am. So that would be it. So after 6 months, ma'am, then I would like to reassess the PLA2R values. In case if there is improvement, then I would like to the repeat dose is not required in that case. If it is same, then I would like to repeat a course of rituximab. That would be another 4 injections of 375 milligram per meter square dose. In case if it is increasing, then either I can repeat rituximab injection or I would like to change it to modified Pondicherry regimen.
Okay, so what I meant to ask you was basically you gave rituximab. What starts happening to PLA2R? What starts happening to his proteinuria? And in what time frame? Because the patient wants to know कि मेरी सोजन कब खत्म होगी, मेरा protein in your parlance protein loss कब खत्म होएगा, ठीक है? So this is what he wants to know, and that's what I want you to understand.
So ma'am, usually
On ground terms.
ma'am, usually the PLA2R levels will improve if there is remission. The PLA2R level will go down first, and usually the proteinuria continues for a longer time, about 3 to 4 months. It will continue.
So the
despite-
response in proteinuria may take at least 6 months.
6 months.
That's what you need to understand.
Yes, ma'am.
That's fundamental. कि मरीज को भी समझा दो टाइम लगेगा रिस्पॉन्स आने में, so that he doesn't get impatient, you don't get impatient. That's very important for the physician as well as the patient to understand. That it's going to take 6 months for a response to come. Sit tight. Okay.
So that,
I can't remember recommendations, how often should be repeated, whatever, but this is fundamental. Response आने में time लगेगा. Okay.
कितने intervals पे देते हो आप rituximab?
sir, either it can be given once a week or it could be given once in 2 weeks. But in that case, the dose would be the double dose. That is 1 gram.
So how do you know that what you want to use here?
Sir, in his case, since the proteinuria is very significant, we would want to have if possible, a quicker effect of the
महीने लग रहे हैं, क्या फर्क पड़ता है? Every week 2 या 15 दिन में तो is there any difference in the data? I don't know. At least.
Hey, see, the thing is that both of these regimens have come from 2 different trials. Now you need to go back and look into which were more serious patients in which trial, more proteinuric patients in which trial, and then you get the answer to that. So the trial that used lesser doses at frequent intervals were patients who were less sicker. And the patients who were more sicker, who had heavier proteinuria, had higher doses at longer intervals. And do you think there is any reason for doing an anti-PLA2R antibody level before you decide which patient has to undergo which kind of regimen?
Yes, sir. So because anti-PLA2R, which is suggestive of a primary membranous So in such patients, we do the immunosuppression modalities. In case of secondary membranous, where we know what is the secondary cause that is leading to it, we usually try to correct that disease process, which will in its way correct the membranous nephropathy.
So basically, when you're looking at an anti-PLA2 receptor antibody level which is way above the threshold, which is a very high level. So these are patients who are not going to respond very well. So their baseline titers are very high. So these are patients in which you will have it will be very difficult for you to get them into remission very quickly. So these are patients in which you use a higher dose. And when you use a higher dose, obviously you're hitting the B cells very hard. So then you have the liberty of spacing out the dose. How do you maintain these patients? Suppose I say, so what if I was to ask you, what is the difference in the complete and the partial remission rates between modified Ponticelli and the various rituximab regimens?
I said the remission rates are usually like 30% will have a remission, 30% will have recurrence, and this is the
30% remission rate. Complete
That's
remission.
irrespective of
the
Yeah.
specific treatment.
So
That's
this
the
is for the
natural
mild and the
history.
moderate disease what you're talking about. These are
No,
very
he's talking about the natural history of
Natural
overall
history.
membranous.
So these are mild and moderate.
30% one.
These are mild and moderate.
Natural history.
Not the severe ones. So now, what is the complete remission and the partial remission when you're using modified Ponticelli versus rituximab?
So for modified Ponticelli, it's about 80% at the end of 1 year, and it is 60% at the end of 5 years. The remission rate in modified Ponticelli. Rituximab, sir, sorry, I don't know the specific.
So I'll give you rituximab is 60% at the end of 1 year. And you're saying now modified Ponticelli is 80% at the end of
1 year, sir.
1 year.
What's the flip
So
side?
I
of
would
this?
say that I would still want to use modified Ponticelli. Why would I want to use rituximab?
So the relapses are lesser in rituximab as compared to modified Ponticelli.
At the end of what? Because now you have modified Ponticelli up to 10 years. You have now outcomes up to 10 years.
More than 10 years, I mean, specific set. The time frame I don't know.
So there has to be a reason why rituximab is becoming so popular. Otherwise, why are people not using modified Ponticelli? Why you
That's
talking
what I
about?
was trying to ask.
One
What's
was,
the flip side of Ponticelli regime? Or modified for that matter? I still hate it.
the
Right.
relapse rates are higher. So
The
it would be
relapse
lesser.
rates
It is
would be
lesser.
lesser.
It is
No,
lesser.
you're right in what you said first. But why is modified Ponticelli still not used? That's what ma'am is asking. And why is rituximab preferred?
It's
One
a
is
less
the
toxic.
Side effect
negative
profile
side.
mainly is the reason.
Exactly. So the adverse effects with cyclophosphamide are much higher.
Much higher.
Infections.
Infection.
Much
Yeah,
higher.
those are the adverse effects. Infections are higher.
Mm.
So that's why no one would want to use cyclophosphamide. It's a very toxic regime. It's easy to say 1 gram methylpred, but methylpred 1 gram is horrible. High dose prednisolone and cyclophosphamide are
Risk of infection.
very toxic things.
So if you had a segmental variation of membranous, that is, you have a membranous with segmental lesions, how would you treat such patient as compared to patients who had just plain membranous on biopsy?
It's a tough call.
So I would like to continue with the.
Have you heard of the segmental variant of membranous?
What I am getting is that if there is development of maybe an FSGS,
No,
secondary FSGS.
I don't think he's referring to that.
Yeah, so this is basically he's close to it. So
Okay,
these are patients,
you meant FSGS.
Yes, so these are patients who have
Sclerosing.
segmental
Segmental
sclerotic
occurred,
lesions
so-
along with membranous, because FSGS like MPGN is now gone away. So now FSGS is also going to lose its, because everything in the end goes towards a segmental sclerosis.
Yeah. The reparative process will ultimately lead to
Scarring.
desegmentation. So in that case, sir, then the use of steroid won't be that useful once that segmental sclerotic changes have occurred.
No, so if you have somebody with segmental lesions versus no segmental lesion, is there anything on the serology that you would like to do which will tell you that I want to really give some kind of an immunosuppression or no immunosuppression? Because these are patients who are not going to really respond very well. Anything that will guide? which is there in KDGO also. So there's a part of KDGO guideline which tells you from Catran analysis that there's a molecule known as alpha-1 globulin. It's beta-1 glycoprotein and alpha-1 globulin. So when you use these titers, titer of more than 2 is more predictive of non-responsiveness. So you have segmental lesions, you have titers high. It's best to give what you were going to give first. In which you had, no, not rituximab. Non-immunosuppressive.
Oh, in that, okay.
Your
And
telmisartan.
in that sense,
Yeah,
and
your telmisartan. Because here, even if you give immunosuppression, you're not going to be able to reduce the disease burden so much.
So finally, I think we are about to finish. Where would you put your bet? Minimal change, FSCS, membranous. I'm for minimal.
minimal more after the discussion. I mean, if like what all you mentioned, ma'am,
At least hypertension नहीं है.
nahi hai,
We
ma'am.
could come back to minimal.
Considering the fact that minimal would be the
And you completely eliminated it from your list. So anyway, you can get back to us whatever is the biopsy. You don't even have a verbal report yet.
Ma'am, the provisional part, ma'am, actually I could not gauge it till now, so I mean I could not collect the thing for sure.
So when you get such a case, at least you should have a biopsy report. Otherwise, there's very little to discuss about. That's a main problem in such cases. There is nothing. So at least the biopsy, if we had the biopsy, we could have made it more entertaining. So इतना simple ढूंढ के लाने के लिए थोड़ा बहुत complications ढूंढ के ले आने चाहिए. So I think let's call it a close. Anything else? Anyone wants to ask anything, comment, or anything? Nothing? Sure. Let's call it a close. Anything else? Okay, folks, thank you.
Thank you, sir. Thank you.
Thank you all.